who is Distinguished Professor of Microbiology and Immunology and Obstetrics and Gynecology, Director of the Training Program in Viruses and Cancer at the Penn State College of Medicine. So that is based in Pennsylvania, my understanding, one of the leading academic medical centers. Prof. Craig's team is the first to grow native natural infection human papillomavirus. I know it's very challenging to grow that virus in high enough quantities for laboratory testing. You see, for bacteria, it's easy to grow, unlike those organisms. He has published several research papers on disinfectants commonly used on ultrasound probes. Professor Craig Myers, it's all to you.
All right, thank you. So somebody, I've been told will control my slides. Good afternoon to you. It's still morning here, but so we can go to the next slide. So just, a rundown of some of the things I'm going to be discussing today. The learning objectives are, what are the HPV cross-contamination risks in ultrasound usage, and what are the different HPV research test protocols that can be used to test different disinfectant technologies, and how does HPV research support clinical change in ultrasound probe reprocessing. So next slide, please. So as you all know, human papillomavirus causes greater than 90% of cervical cancer in the world and greater than 60% of anal genital cancers. We do have a very effective vaccine that could eliminate this problem altogether, but we have to get people to use it first to eliminate the problem. So we will continue to take care of people that have cervical cancer and other cancers due to HPV. Next slide, please. So what we know is that transvaginal probe contamination can occur despite using probe covers and definitely using low-level disinfectant technique. We know from the literature that about 13% of probe covers have tears that are either pre or post-vaginal ultrasound examination, and that 80% of the probe handles have residual pathogens on them, and that would include things like MRSA and others. 62% of the transducer cables have been shown to have microbial contaminations too. So even in facilities with protocols, these probe handles still can have contamination after the disinfectant protocol has been performed. We know that low-level disinfection is not sufficient. That's been demonstrated by the results of a retrospective cohort study using linked national data sets from Scotland. And so, summing up this slide is that, probe covers aren't necessarily going to protect, and you can't use low-level disinfectant to clear HPV off of these probe handles. Next slide. So just a little background into my own research. We have studied how different strains of HPV cause cancer, especially the high-risk types like HPV 16, 18, and others. As mentioned, we were the first lab to develop a technique to grow natural high-risk HPV that had infectivity, and we could use it to test different techniques, to block infectivity, like using neutralizing antibodies, microbicides, and in this case, using different disinfectants. We, over the years, have learned how to produce high titers of mature virus. And we've been doing this now for over 35 years. And there's much more than I have time now to go into, or you probably want to listen to, but we have done a lot of studies to make sure that our virus is highly infectious and highly mature. You need to know this before you do the studies. You need to know that your virus is mature and structurally stable, because this will provide the worst case scenario as required by FDA and other organizations in testing. Next slide, please. So we have published several research papers that support evidence-based practice to integrate HPV research findings with clinical expertise and best clinical practice. Back in 2014, and I'll show you more of this in a minute, but we published a research where we tested HPV against many common disinfectants and showed that many of these disinfectants are not effective at killing or inactivating human papillomavirus. We've also published research tests with results that do show that the Germatect Anti-Germix SI and Hypernova Chronos device, the Tristal Trio wipe system and dual system, and the Nanosonics Trophon EPR system were all shown to kill or inactivate both HPV-16 and HPV-18 in vitro. So our HPV studies provide some data for best research evidence to help change clinical practice and mitigate HPV transmission risk from ultrasound probes to patient or staff. And this ensures a quality healthcare outcomes when using ultrasound. Next slide, please. So there are different ways you can test disinfectants, or specifically or particularly with HPV. One way is the suspension test. Yeah, I think everybody's probably familiar with this, but it's just mixing the disinfectant with infectious HPV in a tube and then purifying virus out of that and testing for residual infectivity after a certain contact time has been done. And this doesn't necessarily represent the true situation where virus is on the ultrasound probe surface. So then there is the carrier, the coupon test, where we put the virus onto material and dry it and then do different tests. And the first one, we took HPV and we placed it directly on probe surfaces. So we had actual probe devices and we dried the virus on the probe surface and then followed the manufacturer's instructions for use. And we were able to test the efficacy of disinfectants directly on the probe surface. Another way that's commonly used is to take the coupon or the disc that's made out of the same material as the probe, as the ultrasound probe. We dry the virus on that. We soak that spot with disinfectant for a certain contact time, and then we clean up the virus. We stop the disinfectant, we clean up the virus, and we test for residual infectivity. And then finally, it's very similar to the last one. We dry the virus on the coupon or the carrier surface, and then we place it inside of a device such as the Hypernova Chronos device and run the system, and then afterwards test for residual infectivity. Next slide, please. So this is our first study. It was back in 2014. We tested for the susceptibility of high-risk human papillomavirus type 16 in this study to common clinical disinfectants. So what we did was we just selected a group of surface disinfectants and hospital sterilants to test in this system. And in this system, we use both our naturally grown human papillomavirus type 16, and we used a recombinant particle of HPV-16 called quasivirion, just to see if there was any difference between the two. And you can see that between the two types of particles, you can see that isopropanol and phenol were quite active against the recombinant particles, but were not active against the natural HPV. The only things that we found that were active in this study against the natural HPV was a 1.2% PAA silver solution and bleach or sodium hypochlorite. What was interesting was that we tested GTA and OPA, and we found that they were not active. They had showed no efficacy in inactivating infectious HPV. So summing it up, this study showed that HPV-16 is a very highly resistant virus, more so than other non-envelope viruses previously tested. We compared the recombinant particles with the naturally grown particles, and we grow these particles in a three-dimensional organic typic human epithelial culture system. And that the test results showed that many commonly used clinical surface disinfectants and sterilants were not effective in inactivating HPV. Next slide, please. This is just one of our other studies where we used UVC radiation, ultraviolet light C radiation, to test its effectiveness at inactivating human papillomavirus. In this study, we used both 16 and 18 human papillomavirus. We used the anti-Germix S1 device. And if you look at the graphs, you can see that we used, in all our studies, we use a 5% soil or bovine seromalbumin to represent soil. But in this study, we also used hard water. In either case, the device was able to effectively knock down the infectivity by over a greater than a 4 log drop in infectivity as required by the FDA. So this strongly shows that these devices and systems that can inactivate HPV. Next slide, please. So the aim of that last study was, as I mentioned, just to show how UVC light can disinfect both HPV-16 using a coupon or carrier method. And again, the coupons were made out of the same material as the vaginal ultrasound probes. We used very high levels of HPV-16 and 18, and these were dried on the coupon and then placed in the Hypernova Chronos anti-Germix device and ran the system according to the manufacturer's protocols. And that we showed that this high-level disinfecting Chronos was able to demonstrate a greater than 4 log reduction in either HPV-16 or HPV-18. Next slide, please. So in conclusion, we believe that the HPV research is a major driver in changing clinical practice, or should be, establishing new guidelines, and clinics should be adopting new technologies such as UV light or some of the other systems that have been carefully studied. The published papers show that ultrasound probes are a potential source of HPV transmission. This is a risk that poses new challenges for the infection prevention. Not all research is of sufficient quality to inform clinical decision-making. Therefore, you would need to critically assess the evidence before you can use it. For example, comparing low-level disinfecting practices to high-level practices, how the virus is produced, is it mature and structurally sound before you run the assays? And so there are 3 major aspects of evidence that I think you need to critically evaluate. One is validity. Can you trust the data? The FDA requires a 4 log reduction. Did you see that in your assays? Impact. Are the results clinically important? And of course, applicability. Can this be applied to your patient population and usage of these ultrasound probes? And I think that's the end of my slides. There's a group of references at the end. We don't need to go through the references, and I can stop here and take any questions that anybody would like to ask.
Thank you so much, Craig, for an excellent and very neat piece of research and presentation. Thank you. So any questions? There's one question, which is about, should we be concerned about